Good afternoon, everybody. We will get started with this session. And as most of you are probably aware, this is a session that's been sponsored by Perfuse MedTech. We have a panel of 4 of us to speak today, and we're talking about the geko device and how the body of evidence continues to grow for this. So I'll be opening this up, and then you'll hear from each of the speakers, so Robin Evans, Keith Harding, myself, and then Dr. Sibbald, and then we'll have some questions at the end. Just by way of sort of, what we're covering and the learning objectives, so we'll be initially looking at discussing the geko device or muscle pump activation device, how it works and its application to different types of wounds. Will be a discussion of the current evidence, which Dr. Keith Harding will talk about some of the research work that he has done. I'll cover the review of how this applies in clinical practice and touch on where it sits in the Canadian consensus statement on the management of venous leg ulcers. And then Dr. Sibbald will talk about some case studies, particularly as it relates to patients with arterial disease. So without any further ado, I'll hand over to Dr. Robin Evans, who will give us the first talk.
Hi, everybody. I'm going to stand over here. It's that podium is taller than I am. So I have the following conflict of interest, but nothing that affects the talk today, and no mention of any other companies. So the geko, it's really important to know how it works. Worst thing is, because the first time I put it on, I thought, well, I don't really know what I'm doing. So I'm going to walk you through this. It's a muscle pump activator, affects the peroneal nerve, and that nerve is located on the outside of your leg. It's very tiny, well, it's the size of a watch, but it weighs only 10 grams. And I was trying to give that some point of reference, so 10 birthday candles, if you can imagine how heavy that is. It's not very. It's self-adherent, there's a gel on it, so it's self-adherent to the skin, and there's it can be put on by anybody, patient, caregivers, and you can just continue on your normal activities of daily living. You walk around, there's no impairment in your movement. It delivers a painless impulse, which is 1 hertz. And I would recommend going to the video, because the video is on the website for geko is well done. If you make sure you look up geko medical device, not geko, because you get a lot of interesting stuff from that. But that video is very informative, tells you exactly how to do it, 2 ways to landmark. This is what it looks like, very small, size of the wristwatch. Just point out the fibular head, that's where you landmark, and that's where that first line says there. The blue one wraps around the front, and the white wraps around in the back of the leg behind the popliteal fossa. And on the left leg, that geko will be upside down. So this is what it does. It's activating these muscles, and you all know these muscles from training and anatomy class, but they're all the muscles on the lateral side of the leg and into the foot. So that's where you're getting the big impulse. So what does it do? Well, there's videos of what it does, but it actually moves your foot out and up. It gives you a little twist. And it's, I don't know, how many people here have put one on before? Yeah, well, that's good. It's good to hear these guys have. Yeah, it does give you a little twitch. And of course, when you're walking around, there's no twitch. It's when you're at rest. And most people do not complain about it. So what's it addressing? Well, it gives you this isometric contraction, and that's good for the calf muscle. It moves fluid and it moves blood, and that's exactly what you want to do. So it's a muscle pump activator, and that's exactly what the person putting that geko device on looks like. It improves blood flow. We think it, improves blood flow to the arteries, but also it improves blood flow to the veins and can be used in peripheral artery disease, diabetic foot ulcers, venous leg ulcers. We don't think of venous leg ulcers as being in need of oxygen, but venous leg ulcers very much have venous ischemia because the fluid is locked in the capillary areas, nothing's moving out, there's a lot of inflammatory exudate. So the fluid there, the perfusion in that local environment of venous leg ulcers is not good. So this also improves the microcirculation. And this is important because, I mean, as much as you can have good blood flow in your big vessels, when you look around certain wounds, they're scarred down, lipodermatosclerosis around those venous ulcers, the local perfusion around those ulcers is not good. And as I tell everybody and all my students, perfusion is the currency of healing. So you have to get the blood flow there. And sometimes we need an extra push. What else will help? So Dr. Harding has done this study using this laser speckle contrast imaging, which is very impressive. It shows improved blood flow not only to the peri-wound, the wound bed. And look at those numbers. That's significant. 225% is a big number, 67%. And that's why we think this helps so much in healing these wounds that are not getting the perfusion they need and getting rid of the fluid. Because fluid inhibits perfusion as well. So E-stim has been talked about a lot, and I must admit I've never actually used E-stim, but this is what it looks like. It's sort of electrodes on both sides of the wound, and there's high voltage, low voltage. And what it does is it's supposed to improve the cell attraction into the wound bed and improve function and release of growth factors. Now, there's evolving evidence for this, and it is being used. It is not a muscle pump activator, though. That's a big distinction here. You can see this is put on a completely different type of mechanism. So if you compare these things, because we all talk about TENS as well, so we know about the geko. I just told you about EMS. The TENS machine is affecting the sensory nerves that go to the spinal column, and that's what causes the sensation of pain. It is needing to be worn many times a day. I'm in family practice, and I often recommend it when it's necessary, but it has nothing to do with any kind of muscle stimulation. So, is Rosemary Hill in the room? No. Well, there was an episode of Shark Tank recently, and the geko has a few different uses. You can imagine it's a muscle activator. Anyway, she wrote this email to Jeff because it was Shark Tank had this thing called Firefly on it, and wondered how is this different. Well, it's a cute story, but it is a member of the geko family, kind of. It's a different. It has different amount of energy and little different electrodes, but it is being used for hockey teams. My Maple Leafs might do better this year. We'll see. They can, if maybe geko could give them more or encourage them. And now, of course, we need the Jays, because we really would like the Jays to do well. And so if you think about it, muscle pump activation in any way, you're removing all the bad stuff. So these guys have been playing all day. They've got lactic acid, buildup of nutrients that shouldn't be there. So removing that and improving the muscle function does make sense. Anyways, that's the little tidbit. I'm going to turn it over to the three big guns here and have a seat.
Thanks, Robin. Thanks for that overview. And we go on now to Dr. Harding, who will talk about some of the clinical evidence for us.
Thanks very much, Dr. Stacey. You must have been really bad to have a second dose of me in 2 days, but here we go. The same conflicts of interest I had yesterday, still present today. Talking about this device, which I have the pleasure and privilege of being involved in developing over a number of years. I have no stake in the product or the company, but I've really been impressed as a new way to approach problem wounds in the lower leg. So this is reporting a study that we published, a study that we undertook a few years ago, and it shows, although I have an interest in the International Wound Journal with Douglas, we will publish this in another journal, so there was no friends and backhanders to actually get this thing published, and it's the journal that's endorsed by the Wound Healing Society in America. So, I just realised that my glasses keep and I'm looking down there and I can't see a bloody thing. Wound Healing Society. Boss.
Why don't you use the handheld?
Yes, boss. I will, right, boss.
Move this way. Thank you.
No,
Yeah.
no dancing. You embarrassed me yesterday. Do it
What
again.
if the table collapses? Hello.
Definitely a doctor. Definitely a doctor. Not sure. Report on this clinical trial using this device. And one of the things that we did with it, and one of the things I think is interesting, not only because of what it is, but the design of the study. One of the challenges that we've all faced, and I'm not speaking as an official regulator or an academic, I'm speaking as a practicing clinician, is how do I know whether something's going to work or not? And one of the things that's interesting in the design of this study is we put the patient in standard of care for a period of a few days or a few weeks, and then we randomized those patients into either receiving, in addition to standard of care, geko or just continue with standard of care. And the idea we had was, could we look at the trajectory towards healing? Certain person on this panel has been banging on about 40% healing in 4 weeks, Sybil. And we were concerned that could we demonstrate, not complete healing, although that's something we need to be done for regulators, but to show what was the gradient of that curve, or what was the rate of healing with standard of care compression, which everybody should be getting, as compared to rate of healing when you put the geko on top of it. And that was the goal of this particular study. And the important thing is that if you look on the right hand of this slide, the fact that there is consensus statements around self-controlled study structure, not self-controlled the product and the patient could do their own thing, but the fact that this is a design that's accepted by the regulators as being an appropriate way of evaluating new interventions. The other thing that we did, and this has been something I've had an interest in for 30 years, is how and what do I measure in terms of dimensions to show that the wound's getting better. And as a result of a lot of investigations over a number of years, we've come up with this thing about wound margin advance. It's not area, it's not circumference, it's not radius or diameter, it's the wound margin advance that you should be looking at. This is the study design. It looks complicated, but it isn't. It's just different to what you would have seen previously. And the fact that what you've got, typical of me, the batteries run out.
There's no, it doesn't work.
Does it? Oh, thanks. Like me. So the study design is screening, recruitment at day 0, a run-in phase receiving standard of care from day 0 to day 28, and then randomized into going into either, as I say, compression alone or geko plus compression, and then following them from days 28 to days 56, and then a long-term follow-up up to 3 months. But as I said, we weren't in this study set up to look at healing, it was just progression towards healing. Here are the subject demographics, the group, the standard of care group on the left, and the standard of care plus. There's all these abbreviations, but it's basically the same thing, calf muscle pump activation, but that's neuromuscular electrostimulation, which we use in the UK because we speak proper English. The important thing is to recognize that in study design, the groups are comparable. That's all you can say from that. And then when we looked at the flow chart of the study design and subject accountability, at day 0 screening, you can see we had to identify or recruit 171 patients, but you can see the attrition through various factors going through the study, both in terms of the run-in phase, and you can see the reasons at the bottom table in that blue box is that doing trials on chronic wounds isn't easy. There are lots of reasons why you may lose them for one reason or other. And then follow down to the second part of the slide is when they're randomized into the treatment or control arm, you can see the number of patients underneath that where they healed or didn't heal. And also the fact that we have the end of trial when we had those patients. But look at the numbers. When it started off with 170, we got 28 in the standard of care plus geko and 22 in standard of care alone. This is what we would expect to see, and was one of the patients from the study, and you can see that there is a difference in gross appearance of those wounds on the two legs of standard of care versus standard of care plus geko. But we all know that that's weak evidence in terms of robustness, and you can't judge, make too many judgments just on a single case. This is where we started to measure this wound margin advance, and this is where you can see pictorially the two phases of the study with standard of care in both graphs, and then the intervention and one received in addition geko. And that's where the stylized slide at the bottom right is there, and it showed that there was a significant difference between the two treatment arms when you added in geko. And the important thing is that this is geko applied 12 hours a day as compared to standard of care alone. So both of them had treatment, accepted treatment, which is compression. There was only half of them randomized to receiving something in addition. And here, looking at healing rate, which is another term perhaps more comfortable with, that talks about the rate at which that wound was getting better. And here we have the healing rate in the run-in phase in the grey column, and the healing in the treatment phase with standard of care and geko in the blue colour. So there is a difference. It's statistically significant, and it's over twice the increase in healing rate in the geko treated group as compared to compression alone. And the important thing is that we believe this may be something you could look into the design of development of lots of other interventions to look at the effect of one single factor, one single treatment, but then look at the addition of second or even third, fourth treatment on it, depending on what that graph is. Because the important thing is that the standard of care arm along the control arm, there's not much difference in that period of time that they were just receiving standard of care. Again, interesting to note, but here is the plot of showing standard of care plus geko, and that's statistically significant from before and after receiving geko. So there's a difference in these two groups. The other thing that's interesting, and that we haven't answered the question yet, and hasn't been fully answered, is one of the observations that we and others have made with this is if you actually put geko on a leg, it has an impact on reducing pain. Why that is, you don't know. I would hypothesize it probably has got something to do with control of edema, but I haven't proven that. But the important thing is you can see in this slide here that the pain did decrease in the muscle pump activating arm, which is the geko arm again. And then you see the difference between the ones in the blue column as compared to the grey columns on the right of the standard of care arm alone. It's not only strange people in Wales who talk funny and spend most of their time on aeroplanes who've had positive experience. Here is a paper, a piece of work done by people in Canada, and showing that in their work, the progression towards healing in this standard of care cohort was a mean of 40 days to healing, as compared to the one when we add in the retrospective standard of care cohort, looking at the both. You can see the importance is that the healing times are much improved, almost half. Now, it's not a study that proves it's effective at healing. It's just giving you increased confidence it's having some impact. And when you look at published literature or published studies that have been undertaken, again, the grey columns is just compression. The blue columns are compression plus some form of compression, some form of electrical stimulation. And you can see there's a difference there. So interesting. It gets me really believing we're on the cusp of something that can actually make a big difference in the management of lower limb ulcers. And this self-controlled style, study style, is something that's accepted by regulators. The percentage area reduction is a useful metric for comparison. Intermittent use of it on the common perineal nerve, or those of us who are slightly older, Dr. Stacey, lateral popliteal nerve, significantly accelerates healing rate. Perceived pain is significantly reduced with this. So hopefully that's giving you some background as to why we think this is a potential game changer. Thank you.
Thanks very much, Dr. Harding, for that. And I forgot to mention before, this is the first time the four of us have been together on the one panel presentation. So it's quite a unique experience for all of us, I think. We've often, sometimes one or two of us, or even three of us, but never the four of us together. So thanks for Dr. Harding from coming all the way from Wales for this. So what I'm going to talk about is how do we put these research findings into clinical practice. And this was the reason, or one of the reasons that we looked at that Canadian consensus statement on the management of venous leg ulcers. Just some conflicts of interest there from myself. So with that, what we endeavoured to do, bringing together a group of clinicians from across Canada with different disciplines, physicians, nurses, NSWOCs, therapists, was to look at a number of new research findings and how they should be incorporated into how we manage venous leg ulcers. And one of those was the muscle pump activating device. But there are others that relate to how we use other advanced wound care products. So this was trying to encompass a number of things within that. But I'm not going to go through the detail of that today. I'm just going to go through some of the key elements and where the muscle pump activation device fits. So that consensus statement was looking at a variety of things, and I think they've distributed some copies of that onto the table, so you can have a look and see what else is within that. You can also download this from a website for free, which I'll show you at the end. But this is looking at the standard things, the clinical features, the investigations, the diagnosis, looking at how you treat the underlying problem, which is the key thing in venous leg ulcers, treating the calf muscle pump, and then how you treat the wound. But today I'm just going to focus on what we do to treat the calf muscle pump function. And one of the key elements, as I mentioned, the standard thing we all do is to put compression bandaging on patients' legs, and we encourage them to exercise. And the compression bandaging, in most cases it's bandaging, but it could be other forms of compression. But that's really the key element that's been used for centuries, even millennia, for people with venous leg ulcers. However, we all encounter a lot of patients who can't tolerate compression. And it may be because they've got reduced ankle brachial pressure indices and we don't want to put compression on, or that they simply find it uncomfortable, painful, and they won't wear it. So what we normally do is we reduce the level of compression, use one of the light variations of the compression wraps. And if they're truly having difficulty, we may just put on a stockinette of some sort. But from the evidence that has been shown by the two speakers before, we now have another way of helping to improve and optimise that calf muscle pump function when we can't apply compression. So the muscle pump activation device is something that we should be utilising in these patients, because that goes from poor compression to good compression, poor functioning of the calf muscle pump function to good functioning of the calf muscle pump function. And obviously, those who can't tolerate optimal compression, our goal is ultimately to get them there, but this helps us to do something to support them. And sorry, we're just not moving on. And as Dr. Harding alluded to, there is this concept of what to do when wounds aren't healing in the normal trajectory. And even though they might be improving slowly. And if they're doing that and they haven't achieved the level of healing that we believe is optimal, and many people use this 30% at 4 weeks, then we have an additional thing we can do. If they're not doing that, we've got to do standard things, make sure our diagnosis is correct, make sure they're using the compression, make sure we've got the right compression, do all those things, make sure they've got an exercise program. But if they're still not healing, then we should be adding in the muscle pump activation device, because that further improves calf muscle pump function. And from the data that Dr. Harding has presented, that really is a thing that significantly helps the healing in those patients. So definitely that's another approach to look at this. And then obviously the consensus statement will speak about other things beyond that to look at advanced wound dressings. But you're treating the underlying problem. Compression plus muscle pump activation device is what is needed to optimize the function of that calf muscle pump. And I'll just give you an example here. This is a patient that I've sort of seen during this last year. When this patient came to me, they're 89, pretty active 89-year-olds, had an ulcer when I saw her for 12 months. She'd had the veins treated, so she'd had EVLT or endovenous laser therapy to obliterate the superficial veins in that leg, because she had quite significant reflux in those veins. She had good ankle brachial pressure indices, so should be able to tolerate compression. She hadn't been using compression that well, so we got her into good compression. So the beginning of this graph is from when I first saw her. She had ulcers on the medial and the lateral side of the leg. The upper one is showing the one on the medial side. And you'll see that once we got her into compression, the ulcer sort of went backwards a little bit, but then it started to improve. But if you look at that rate of improvement, it's not anywhere near 30% at 4 weeks. So you see the arrow, we added in the MPA or the geko device. If you look at the bottom line there, you're also looking at a level of pain. So she was having quite significant pain, and to the point that Dr. Harding has indicated, once we added that in, firstly, the wound started to improve, but secondly, her pain also reduced. It improved, but still not quite at the rate we were looking for. So after another, we gave her 4 weeks. After another 4 weeks, we added it in again. And then you can see it improve further. Her pain, which had gone back up again, went down again. I bring your attention to that dotted line. Just look at the top one. If we'd carried on the trajectory we were on, that's where her healing would have carried on to. So it would have taken an additional 6 months, at least, for this wound to heal. So by doing this, we gave her 6 more months without a wound. We also reduced the cost of actually treating her. So one of the things this leads into is, what are the benefits for the patient? What are the benefits for the system? And I'm just going to touch very briefly on this. Tomorrow I'll be talking to a poster on the cost effectiveness of using the muscle pump activation device in patients with venous leg ulcers. So we did some projections from the healing rates from Dr. Harding's study. We worked out what the costs of treating a chronic venous leg ulcer are in Canada. And we looked at, so what are the benefits with this? So from those projections, if you treat a patient with this just for the 4 weeks, as in Dr. Harding's study, you save about 60 days of having a wound, so a couple of months less for that patient. But not only that, you actually save money. You save nearly $1,000 in treating that patient. And so that's a significant improvement, mainly for the patient, because then they've got 2 months less of having a wound, but it also helps the system because the cost is less. That's in spite of having to pay for the geko on top of that. And if you project that out, then the other group of wounds that there's some recent data on out of the UK is those that have had long-standing wounds, so not healing for 12 months or even longer. And there's some data that if you use this muscle pump activation device continuously in addition to compression, on average they'll heal within a couple of months. And if you look at those ones, if you can reduce healing that's really not happening for 12 months to healing in 2 months, you're actually going to save a significant amount of money, nearly $10,000 per patient. So think of those long-standing patients that we all have. You've now got something additional you can do to help them. You give them 10 months a year less of a wound, and you save a significant amount of funding. And this is really to help you when you go to your healthcare administrators, and anyone in the room who is a healthcare administrator or helps to support and fund home care. These are the sort of savings you can look at from a provincial or a national projection. So if you look at just projecting those numbers, in Canada, and we've used the prevalence of venous leg ulcers, which is an internationally published number of 0.32%. With those numbers, in Ontario alone, each year you'd save $50 million. If you also look at the ones that have had wounds for greater than 12 months, and again, they represent lots of studies showing they're about 20% of the patients we deal with venous leg ulcers, you save about $100 million a month. And if you project those numbers out for Canada, you can see the numbers are even greater, and in total that's about $400 million a year. So there is a strong argument financially that this is a benefit. But the key for all of us as clinicians is those patients get their wounds healed, which is the big thing they want done. But when you're talking to your funders, this evidence now really says to them, this should be a no-brainer to support this. So this is the access, if you want, to the Canadian Consensus Statement on the Management of Venous Leg Ulcers. It's been published. You'll see if you scan that QR code, you can get to a website, an independent website. You can download this for free. So at this point, I'll hand over to Dr. Sibbald.
Okay, bringing up the rear. The next slide. Whoops, I guess I can do that. Okay, so my conflicts of interest are 50% the Ministry of Health, where I run Project Echo Ontario Skin and Wound to train skin and wound teams. Chymoseptine got us to the Philippines, developed a program. Perfuse is what I'm doing now, and I am co-editor-in-chief of Advances. The last Wound Bed Prep 2024 has 10 steps, and we got 88% consensus with 3 rounds of Delphi of 41 key opinion leaders in wound care. And I think this is an important step, is to look at the evidence and what's realistic for the community. And this is based for when you've got limited resources within your community. And what I'm going to highlight is treating the cause. I'm going to look at the arterial supply and how we can see, is it reasonable for healing? If it's not a healable wound, you probably shouldn't be using a geko device, etc. If it's maintenance or non-healing. We certainly want, with the NERDS and Stoney's criteria, to make sure we haven't got superficial infection, treat topically. And look at the new therapeutic index in January Advances. That's freely downloaded, and some advantages to some antiseptics over others. And patient navigation, I spoke about in the session this morning. We know that we have a muscle pump activator. It's different than e-stim in stimulating the muscle, and not only does it increase the wound bed perfusion, but the peri-wound. And VIP doesn't mean very important person to us. It means look at the vascular, look at the infection, and plantar pressure redistribution. And the Darko boot in Ontario is now on home care, and there are several versions of it. And, in our Guyana project, we had students do the IWCC. We opened a diabetic foot center. We had doctors, nurses, and physiotherapy assistants working together, and we reduced amputation 68% with Darko boots. The audible handheld Doppler is our latest, and it's part of a toolkit through Echo you can get free. You have to attend 6 out of the 8 sessions. The next limb preservation starts in January, and do the skill quizzes. And you could get a 8 megahertz Doppler. The monophasic sound is really a shh, shh, shh. The biphasic sound has 2 definite components. The triphasic sound, and you see this going down below the midline up and down again. First patient is Geo, male between 70 and 79, retired. But look at his smoking history, 75 pack years, and he had stopped. And he was also at one time a heavy drinker, so he had neuropathy, and he had significant pain. And he was first seen in September 2023, a post-femoral artery stent and necrotic wounds on his foot. And they suggested that he have an amputation. I couldn't touch his foot, let alone debride it at the beginning. And so we used MLAW, which is a fancy name for eutectic mixture of local anesthetics. It's 2.5% prilocaine and xylocaine, 2 powders liquidized, and therefore they penetrate into the skin better. We did start the geko device, and we did use, with the vascular surgeon's permission, tubing grip. And by January, he was down to 8 out of 10 pain. We were treating his pain with Lyrica and nortriptyline, and we were treating his nociceptive pain with acetaminophen, a gram twice a day. And by June 2025, we had this down to 2 to 3 out of 10 and intermittent. And as you can see, my debridements got a little bit less aggressive as time went on, but in March, he still had bone showing outside the 4th toe. And if you take a little bit of bone like that off, that is active surgical debridement. It needs to be sent for culture. And he actually healed. And he is from a wheelchair to walking, and has maintained that healing over the last year. Case 2, RGK, 60 to 70, he is a person with diabetes. And we know with diabetes, first of all, the 60-second screen for the high-risk foot is a simplified INLOS tool. A better screening tool, the INLO tool, is really, in my opinion, best for the foot specialist. And it really takes me half an hour to do that tool. You should look at the hemoglobin A1C. His is 6.5. So I know the guy is interested in getting better. And you look at blood pressure. And both the screening, hemoglobin A1C, and blood pressure save the system money if you control it and improve patient outcomes. And he had, interestingly enough, they were going to do a right lower leg amputation in Guyana, South America, and I happened to be there at the time of the project, and we did go through a protocol there and saved that right leg, but he ended up in an emerge here, and in half a day they amputated his left leg because of osteomyelitis in 2017. He then had another acute episode on his right leg, was admitted to one of the teaching hospitals. They weren't getting very far after a month, and he asked to be discharged, and he was sent to Bridgepoint. And he has found his way to our clinics at Women's College and Mississauga for regular sharp debridement. And initially he had bones sticking out at the toe, a lot of slough. This was the first debridement. This is a second debridement. He's on 2 types of insulins, 2 types of oral anti-diabetic agents, and an emergency kit. He's been on lots of antibiotics. He has very little pain. He only takes acetaminophen 500 every 4 hours, and this may be true of some of the persons with diabetes. And yes, he had infection, and we needed to treat it topically, and we are using hypochlorous acid, which, if you look at the therapeutic index, is very good for staph, E. coli, and Pseudomonas, and PHMB was the best actually for MRSA. So we started doing this, and we switched his topical treatment to iodine. We were working with infectious disease on his systemic agent. He had a cart, and this was the way he came into the offices. He was really a good advocate for him, and pain 3 to 4 times in the ankle region, but 0 out of 10. Normally, And this scooter really helped him to do his plantar pressure redistribution. And the ulcer was huge, 18 by 8 centimeters, 4.3 by 7. And we had our protocol. We found another resistant organism, so we're working with infectious disease again. But we have continued to do the debridement. But this is interesting in using the geko device. Listen to this Doppler. And we've really gone from a monophasic to starting to hear a biphasic component in this Doppler. And he did have on Monday tests at St. Michael's, and the toe brachial index on the right has actually improved from the April 1, 2024. And in talking with Michael, we think that in some ways this is like continuous exercise, and instead of having it on for a few minutes or half an hour, it's on for 12 hours each day, that we actually may to some extent improve patients' vasculature locally. So I think, you know, you need a reasonable blood flow for success, and if it's cold foot dependent rube or blanching on elevation, it may not be somebody you should consider. After 2.5 weeks, the Doppler signal actually got stronger. The geko muscle contraction elevation may be working like exercise conditioning, and it was turned off when we did the Doppler, so it wasn't as if the geko was what was improving it at that moment. So I think I am finished and open for questions.
Great, thanks very much, Gary, and thanks all of the panel. And just as a little advertisement, if you want to hear a little bit more about advanced wound strategies and lower limb care, our Welsh colleague has had to return back to Wales after this to help the Welsh rugby team to see if they can win a game or two. But the rest of us will be here, and we'll be helping with some of these webinars. So we're opening up for questions. We've got some online and any in the room. If anyone's got a question, I think we've got a few mics you can go to, and there's someone with a roving mic, I think. You're going to do it? Maybe while we're just waiting for questions to come up, I do have one question. It's for Dr. Harding. Yeah, Dr. Harding, I know in your study you've used the geko for, or the muscle pump activation device for 4 weeks. Do you think that's the optimal number? Do you think there should be a different number? And what's your thoughts on that? Because some patients obviously may benefit from longer. But maybe get your thoughts on that. You may need to turn that microphone on, I suspect. Maybe tap it. The guys at the back will probably turn it on.
Hello.
You got
There you are there. Yes. Actually, 4 weeks was nothing other than the fact that we wanted to measure it over a short period of time to look at that trajectory of healing. In terms of dose for patients to get to healing, that piece of work, as far as I'm aware, hasn't been done as yet. But I see no reason from our early experiences why we couldn't use it for a longer period of time. It just meant they had a constant period of time we were comparing like with like.
Great. Thank you. Yeah, we've got a question down here. Oh, sorry.
Hi.
Oh, up there. Sorry, I didn't see you.
I just wondered if you have tested or used it on anyone with paraplegia or quadriplegia for a lower limb venous type of ulcer at all?
No, but we tested it on, and we have tested the device in persons with diabetes and neuropathy. And we very much got the twitch response in those patients, much to my surprise. And initially, I turned the device up to 10 because I didn't think I was going to get a twitch. And then I got too much of a twitch, and we had to turn it down. And the second patient was diabetic. The first patient was a smoker. And, you know, in smoking, you get proximal disease more frequently in diabetes, a lot of peripheral disease. And of course, there's the calcification issue, which with the handheld Doppler, it's not influenced by calcification. You don't have to squeeze the calf muscle pump. They don't have to be lying flat. It can be done in a chair. And you can record it on an MP3 on your cell phone. And so it's a much simpler procedure. I know Kim LeBlanc takes it everywhere she goes in the long-term care to use the audible handheld Doppler. And it's really changed our practice. And we did validate that in 2015 on 200 patients with the Trillium Mississauga Vascular Lab. But I don't know about the paraplegia and quadriplegia. And even though you get some effect on the muscle and you will get some effect on the circulation, from what we can see, it's a little bit less. But Keith, you may have more experience with that to comment.
No, like you, we've used it on diabetic patients with neuropathy, but I think the issue of the quadriplegia, paraplegia is interesting, and it certainly, I'm sure, will be looked at some stage in the near future.
Yeah, I can make a comment on that. The neuromuscular electrical stimulation has been used in people with paraplegia and quadriplegia, primarily for looking at some form of continence in the bladder and bowel function. It depends on whether their peripheral nerves are still functioning. So to answer your question, you could use it on people with quadriplegia or paraplegia, but see if they're getting a muscle twitch. So if their peripheral nerves haven't degenerated, then the muscle twitch should still be able to be demonstrated. And if it is, then you're going to get that improvement in function. That's what you're looking for, is to get those muscles to contract. Robin, you were going to say something?
I did try it on someone with severe spinal stenosis and nerve root injury, and we were not able to get a response with the pronoid nerve, and he would have been a great candidate for geko. Unfortunately, didn't work.
Yep. Okay.
Hi.
Yep.
I actually had a patient who's...
It'll here next, and then we'll go to you. There's one.
Very interesting results for venous ulcers here. My question is there any role for this in people with arterial disease who do not have venous ulcers? I mean, you, Michael, as a vascular surgeon, would have greater insight into this. Obviously, you know,
The two patients I did were both arterial disease, and one of them was smoking and proximal, and one was peripheral and diabetes. I think that the caveat is, and you know, going back to transcutaneous oxygen studies and other things, that in transcutaneous oxygen, it measures the large vessels, intermediate, and what's happening on the skin, drugs, temperature of the room, etc. And what the hyperbaric doctors have found, that if it's 20 and below, they're not going to help them. Between 20 and 30, they'll help them, but it takes longer. 30 to 40, some delay, but not, and over 40, normal. So with reasonable circulation locally, and that's what I checked, and in the person with diabetes, I want to make sure their blood pressure and their hemoglobin A1C is okay, you know, because you're really looking at the whole patient, not the hole in the patient, and somebody that's going to be adherent to treatment. And I really encouraged everybody in non-healing leg and foot ulcers to do a hemoglobin A1C on every patient. And Stefan, I think, you know, even when we were in the Middle East and other places, I think it became very clear that you could distinguish the people that might have a chance from the ones that, you know, were really too far gone.
And I can just add to that. I mean, there is good evidence, and Dr. Evans put some of it up in that slide, that in people with arterial disease and diabetic foot ulcers, the muscle pump activation device does increase blood flow in both the arteries and the veins. And there's also good evidence now that it increases microcirculation. There aren't the RCTs in those groups, that, like the work that Keith has done and like the work that's been done here in Canada, but there are quite a few case studies and some cohort studies that do demonstrate benefit in those patients. Particularly the ones, and where we're advocating for it in those groups, is the people who you don't have any other reconstruction options, because that's always your first point in people with significant arterial disease. Or, if they're at a point where you may be thinking of amputation, a little bit like the cases that Gary's talked about, you can use it to see if you can improve things sufficiently to reduce their pain and maybe avoid amputation. So definitely it has a role, and we'll probably see more coming out on that in the next few years as the data actually increases. So, sorry, over to you now. Yeah.
Okay, so I actually had a patient a few years ago, paraplegic. She had a chronic wound on her ankle, which actually healed. But at that time, recommendation was to wear geko for 6 hours a day. So she was very, I would say, adherent or compliant or vigilant with this. So actually it healed, but she reported very uncomfortable and being painful. So her neuropathy was kind of more severe. But she was still doing this. So the question is about the continuity. So if the patient cannot tolerate 12 hours or more, if the patient has it on and off, like during the day, with some, breaks, will it still be effective? Should the patient try this, or that will negate completely the effect of it?
Well, I can start, and maybe Dr. Harding might like to chime in. I'm planning it on. Maybe the others can chime in as well. But to your point, I mean, it's a little bit like, when you want optimal compression in venous leg ulcers, but when you can't, you go to something less. So if they can't tolerate 12 hours worth of it, if they can tolerate 6, that's still giving them significant improvement. And I think to your point, there is potential for that to help increase the microcirculation. So, and you might even think about, do you do it in several, periods through the day to help? I mean, 12 hours is, to be honest, it's not validated that that's the exact amount you should have, but it's the amount that I think, well, maybe Keith can speak to this, but I think it's the amount that you think, well, that's when a patient's up and about. With venous disease, you want it through the day when they're up and about, take it off at night. It may be better to have it on 24 hours a day, but have it on for as much as the patient can tolerate, because there's good evidence it does help them. But anyone on the panel want to comment on that?
Yes.
Yeah.
Go.
I think the important thing is that what you should be considering is the consensus statement is good basic care first. I'm very nervous about people interpreting what's being said is that we can now avoid surgery for people with arterial disease and just use geko. That's not what we said at all. You give them a good standard of care, the routine care, and you can add this. And I would say that any form of intervention that improves blood flow intuitively would be useful for patients. I think the important thing is that it's not a blanket procedure, but also it's not necessarily that geko is used in isolation. You will still probably continue with compression bandaging or do other treatment, give other local treatments to the patient, but you use it as an additive. And it's almost giving a personalized prescription to that particular patient. This is what we want to do for you, not only to heal your ulcer, but to improve the venous return and arterial inflow.
Yeah.
I think in our system, I really would want the patient to get a vascular surgery opinion. And they either fail the vascular surgery, they're not a candidate, or they've had the vascular surgery and the surgery fails, then I think you can look at them for an echo candidate, but not everybody and not every black foot. And in Ontario, and if you're on home care, think of submitting a special request, but make sure that you can treat the cause as reasonably as possible and that they have the proper diagnosis, etc., before you do that. Because the worst thing that we could do is to have 50 patients all fail as we start this. And I mean, we really want to concentrate on the stalled venous ulcers, but I think there is room because there's no doubt in my mind that it does help people with borderline arterial disease. But if they're still smoking, or if you haven't really treated the cause, or their hemoglobin A1C is 12, you really have to motivate the patient to get proper control first before you use the device.
Sorry,
Yep.
Mike,
Yeah,
just add
Doctor.
that one of the things it taught me, which is not part of the study, was the potential for patient and family members to get involved in their own care. You do not need a healthcare professional to go and put it on and take it off every 12 hours. It's something we encourage the non-professional caregivers to do, because if I'm personally speaking, the only good thing that came out of COVID for the world was the fact that it alerted me to the fact that we often ignore the patient and their relatives as an active participant in the care of an individual case.
Yeah, no, thanks. And there is a comment online about why 12 hours and not 16 waking hours, and the answer to that, there's probably no correct answer to that. I think 12 is a number that actually fits in with most of the age group, you know, for their time up and about, but it could be longer. There's no reason for it to be shorter necessarily. Got a question in the room again?
So very good result about the wound healing. My question is, would you use geko as a prophylactic replacing SCD devices?
What was the
The
part?
subs-
Sorry.
Sorry.
The what?
Replacing what?
Would you use geko as a prophylactic to prevent any venous ulcer instead of sequential compressive devices?
I think you got to be careful with that, but I'd be interested in Keith's comment, because you don't know when they're going to develop that venous ulcer, when they're going to develop the problem. And I think the first thing you have to think about is compression, and optimizing the compression, optimizing the edema control, get the patient exercise. Keith?
Agree entirely. The other thing I think is important is to recognise it's, in my opinion, appropriate to scale up or step up the compression over time, because once you get the pain under control, that they tolerate more squeeze.
Yeah, and we have now the advantage in Ontario on home care of having the Velcro fasteners, which you can gradually tighten with time, and then you're not going through the process of bandaging and bandaging.
Sorry, my background is ICU, so this is where I was coming from. For my ICU patients who are like very immobile, we cannot mobile them. So we use SCD devices for them to have the compression and making sure the circulation is going on. That's where I was coming from. Would you replace those in the hospital settings?
Yeah, no, I understand. The question was she works in the ICU and she wants to prevent the chance of getting a venous leg ulcer because they're not mobile. But I think Dr. Sybil's point is, I think the geko is an excellent device as a treatment modality, and its use is after you've exhausted other things. It's the next thing in the toolkit when you're not getting healing, or I think its potential for pain might be something, you know, was alluded to today, and that's something that needs to be looked at a little bit more carefully. But it has its use, but it's not first line.
So if I can just add to that, though, the other use it has, particularly in those patients in ICU, is for DVT prophylaxis. So that was partly what was in the minds of people when this was developed. And it's particularly of value in the people who can't tolerate medical prophylaxis. So they may have trauma, they may have a bleeding disorder, they may have an intracranial hemorrhage. And there are a number of stroke units, particularly in the UK, that use this as their DVT prophylaxis. So it's certainly an option, you know, in that patient group, more for preventing DVT rather than preventing venous ulcer in that group. We've got a couple of online ones. We've still got a few minutes left. So someone in Nova Scotia is saying that in Nova Scotia this has to be ordered by a vascular surgeon, but the NSWAC would rather that they could actually order it. I'm not sure why that's the case, because really this is definitely something that a nurse should be able to order with their skill set. So I think that's probably something to be addressed really with the individual location, that, you know, because as a nurse, you know, you provide the compression, and this is really just an extension of compression. So I think once it's available in home care, that really should be the case. Another question is the same thing about nurses. Another one's asked, can it be used prophylactically for those people likely to develop varicose veins? That's probably a bit of a stretch, I would say, at this point, would be my comment. And so I think that's maybe something for the future, perhaps, but for now, there's not much evidence about that and probably something to be looked at. We're getting the signal that we're just about time, so maybe at this point we'll look at closing. So what I'll do is firstly want to thank our sponsor, Perfuse MedTech, who supported this session. And I'd also like to thank all of the speakers, for their contributions. Our goal was to have plenty of time for questions, and I think we achieved that. And thank you all very much for attending, and please go to the booth.